If you are past 60 and utilizing a statin for cholesterol management, a dialogue is occurring in cardiology circles that your practitioner might not have shared with you yet. It begins with a caution that the FDA quietly mandated for every statin container over 10 years ago, a notice regarding memory issues, mental fog, and cognitive shifts. Most patients never observe it. Most clinicians never bring it up. However, the data supporting it has only become more intricate since that time. And if you are questioning whether the medication you have used for years is truly providing more benefit than trouble at your stage, that inquiry merits a genuine evidence-based response. I am Dr. LANA Mitchell, and this hub is created for one goal: to provide the latest findings in simple terms specifically for those of us past 60. If you have not followed yet, please do. We post new research-backed material every week, and the data we are exploring today is something I truly feel every senior on a statin needs to hear. Now, let us begin. Statins represent the most common category of medicine in the United States. We are discussing atorvastatin, simvastatin, rosuvastatin, lovastatin, pills that over 40 million citizens ingest every single day. For decades, the routine strategy was basic: high cholesterol data, write the script, renew it forever. And for certain individuals, that method is totally backed by robust proof. But the science has become significantly more detailed, especially regarding people past 60, and particularly regarding what these substances do to the organ that requires cholesterol most, your mind. Let us start with the FDA alert, because this is where most people's attention spikes. In 2012, the FDA mandated all statin makers to refresh their product labels with a notice about cognitive side effects. The revised labels clearly mention that patients have noted memory gaps, forgetfulness, and haziness linked to statin application. Importantly, in most documented instances, these effects vanished when the statin was halted. That final detail is vital. These were not signs of aging. They were not certain. They were drug-induced, and they stopped when the medication was pulled. Now, hold here and reflect on that for a bit. If you have used a statin for years and you have felt that your memory seems less crisp, that you cannot find names like you once did, that dialogues feel tougher to follow, and your physician blamed it all on growing older, that FDA notice suggests your physician might have overlooked something worth checking. Post below right now. Are you currently taking a statin? And have you felt any memory or mental shifts in the years since you began? I wish to hear from you because the trend of what people post in these notes reveals something crucial. To grasp why this occurs, you must grasp something about your brain that most individuals do not realize. Your brain is roughly 60% lipids, and a major portion of that fat is cholesterol. But here is the vital point. The brain creates its own cholesterol internally. Cholesterol from your pulse cannot easily pass what is termed the blood-brain barrier. That is a guarding network that screens what enters your brain. So your brain's cholesterol inventory is basically self-contained, and it is vital for crafting myelin, the guarding wrap around nerve paths. View myelin as the plastic coating around an electric cord. Without it, pulses drag, short circuit, and lose sharpness. Here is where statin category becomes a vital factor that most patients are never told about. Not all statins are identical regarding brain contact. Statins exist in two groups. Lipophilic statins, which means oil-soluble, can pass the blood-brain barrier by slowly soaking through fatty cells. Atorvastatin and simvastatin are the most frequently used versions. Hydrophilic statins, water-soluble, depend on active transport tools and usually stay gathered in the liver instead of leaking into brain cells. Rosuvastatin and pravastatin exist in this group. Many printed studies, including a systematic review found in Frontiers in Aging Neuroscience, have noted that lipophilic statins are linked to higher levels of mental complaints than their hydrophilic versions, and that hydrophilic statins seem to have more guarding effects on dementia threats. A data review printed in 2020 found that hydrophilic statins were linked to a 28% drop in all-cause dementia threat compared to 16% for lipophilic statins. That is a notable gap, and it is one that patients and their practitioners can utilize. But here is what I really want you to grasp, and this might be the most vital point in this whole talk. The debate regarding statins for people past 60 is not only about side effects. It is about whether the pills provide real help in the first place for a massive part of the people currently using them. And the fix depends strictly on one point. Are you taking a statin because you have already endured a heart incident or stroke? Or are you taking it merely to drop a digit on a lab test? Health science labels these two paths by specific terms. Secondary prevention means you have already felt a vascular event, a heart attack, a stroke, a stent surgery, and you are taking the statin to stop another. The proof for statins in secondary prevention is robust across every age group. If this is your case, statins truly save lives, and any talk about quitting should be very cautious. But primary prevention means you have never felt a heart event. You have high cholesterol, maybe some other threat factors, and your practitioner gave you a statin to drop your future threat. And this is where the proof for people past 75 becomes truly vague. In 2017, a secondary review of the famous ALLHAT-LLT trial was printed in JAMA Internal Medicine. The experts checked results in over 2,800 seniors aged 65 and up with hypertension and high cholesterol, but no past heart disease. These were people using statins strictly for primary prevention. The results were startling. Statin usage in this group showed no real benefit in total mortality, coronary heart issues, or stroke cases. In fact, there was a non-significant drift towards slightly higher death in the statin group among those 75 and up. The writers thought that statins might be causing effects in older adults that cancel any heart benefit. This is one trial, and it has limits, but it reflects a wider trend in the evidence base that has moved many board bodies to ask for custom-shared choices rather than routine statin use in seniors without proven heart disease. The European Society of Cardiology's rules go further, warning against what they term as mindless starting of statin use in those past 60, even in patients with high projected heart risk. The U.S. Preventive Services Task Force has stated that the proof for statins in primary prevention for adults past 75 is simply lacking to make a firm suggestion either way. This is not fringe health. This is the central scientific world admitting true doubt. Let me discuss Harold, a 73-year-old former builder whose spouse noted he was dropping words mid-talk. He would be teaching something to his grandkids, stop entirely, and the term he had been seeking would simply not appear. His practitioner said it was normal aging, but Harold had been on atorvastatin 40 milligrams for 11 years. For primary prevention, based only on a high total cholesterol count, no past heart attack, no past stroke. After studying the lipophilic hydrophilic split, his new heart specialist moved him to rosuvastatin 10 milligrams. Within 3 months, Harold told his doctor the haze had clearly cleared. His logic felt quicker. He was finishing his thoughts. Was it the statin move? It cannot be proved for sure, but the timing matched what the data suggests. There is another side effect topic that needs direct focus, and it is one that grows much more hazardous with age. Statin-linked muscle signs ranging from soft pains to a heavy state called myopathy affect roughly between 5 and 20% of patients, with scales rising largely in adults past 65. The most harsh type, called rhabdomyolysis, involves real muscle tissue damage that pours proteins into the blood and can hurt the kidneys. This is rare, but it becomes more likely at high amounts in older patients with naturally fading kidney power and when statins are mixed with certain common pills, including antibiotics like clarithromycin, antifungals, and some heart rhythm meds. If you are past 65 and taking a high-dose statin, your practitioner should be checking your whole pill list often with this mixing risk in mind. Statins also steadily drop blood levels of coenzyme Q10-CoQ10, a molecule used in how your cells make power. This occurs because statins block the same chemical road that makes both cholesterol and CoQ10. The JACC printed a systematic review proving that statins surely lower plasma CoQ10 levels. What stays argued is whether taking CoQ10 surely fixes statin-related signs. The trials are truly mixed on that point. But given the low threat of CoQ10 use itself, many doctors do suggest it as a safety step, especially in older patients. This is a talk worth having with your practitioner based on your own case. What I want you to grasp from all of this is not dread of your pill. Dread is not helpful, and fast shifts to heart pills can bring their own threats. What I want you to grasp is clarity about the inquiries worth posing. And here is exactly how that looks in reality. Step 1, learn whether your statin is being used for primary prevention or secondary prevention. Ask your doctor clearly, have I actually had a heart attack, stroke, or proven vascular event, or is this statin purely to fix my cholesterol digits? The fix to that query decides the whole power of the proof behind your script. Step 2, check which statin you are using and whether it is lipophilic or hydrophilic. Atorvastatin and simvastatin are lipophilic. Rosuvastatin and pravastatin are hydrophilic. If you are on a lipophilic statin and you have noted mental shifts, ask your clinician whether a move to a hydrophilic choice at a matching dose makes sense for you. Step 3, if you are staying on a statin, ask about CoQ10. A widely suggested starting amount is 100 milligrams daily of the ubiquinol type. Ubiquinol, not ubiquinone, soaks in better in people past 50. Ingest it with a meal having some fat since it is oil soluble. Ubiquinol CoQ10 is found at most big pharmacies, including CVS and Walgreens, and online. Look specifically for Ubiquinol CoQ10 brand name to find it. Step 4, keep a short sign log over 6 to 8 weeks, noting power levels, mental focus, and any muscle pains. This provides your doctor factual data to work with rather than vague thoughts. And a vital warning, do not quit your statin fast without your doctor's help. If you have heart disease, there are real threats to quick stopping. This is about learned, shared choice making, not solo action. Let me discuss Eleanor, a 69-year-old former clerk who had been on simvastatin 20 milligrams for 7 years. She went to her doctor with what she called thinking through wool. Everything felt slower, tougher to reach. She had no past heart events. Her statin had been given when her LDL hit 148. Her doctor checked the 2017 ALLHAT results, spoke about her own risk chart, and together they made the choice to fade and finally stop. 8 weeks later, Eleanor said her logic felt sharper than it had in years. She added planned Mediterranean-style food and daily walking. Her follow-up blood check a year later showed her LDL had climbed slightly to 161, but her total heart risk mark had actually gained, led by weight loss and blood pressure shifts. Eleanor's result does not mean every patient should quit their statin. It means the choice merits being made with full data, not on autopilot. The larger point here is one about focus in medicine. A pill given at 55 might not be right for you at 72. Your heart history, your mental state, your other pills, your kidney power, and your own goals for life quality. These factors shift, and the data says clearly that care choices should shift with them. So, let me leave you with the basics. If you are past 60 and on a statin, learn whether it is for primary or secondary prevention. Find whether it is lipophilic or hydrophilic. Have a real talk with your doctor about your mental signs if you have felt them, and explore CoQ10 use if you are staying on the pill. And bring this data to that talk. You are owed evidence-based care, not just a renewed script. Post a note below. Tell me whether you are on a statin, which one, and whether any of these sparked thoughts you have not asked yet. Or post saying shared if you are giving it to someone who needs it. And if this helped you, please follow this hub. Next week, I am checking the one blood test most doctors still do not often order that signals heart attack risk way more precisely than your basic LDL cholesterol digit. The data might truly shift what you ask your clinician for at your next visit. I am Dr. LANA Mitchell. Stay curious about your health, pose better inquiries, and I will see you next week.